and welcome everyone to the educational webinar on COVID-19. We appreciate you spending your evening with us today. Hope you all are staying safe and healthy. And I am Dr. Neeta Dhananjaya, MD, Chair of the Health Awareness Committee of the Indian American Medical Association of Illinois. With me, I have my co-chair, Dr. Sudha Bopalam. We also have the President of the American Medical Association of Illinois, Dr. Sunila Harsur. We are very thankful to the Schaumburg Township Public Library and their staff, Mrs. Sangeeta Bhargava, for working with us in bringing this educational webinar to the patrons of the library and to other audience. Just to give you a brief overview of Indian American Medical Association of Illinois, it is a non-profit organization comprised of Illinois physicians, fellows, residents, and medical students of Indian origin who are committed to professional excellence and quality patient care. Health Awareness Committee, as part of the Indian American Medical Association, tries to bring awareness to important health issues. COVID-19 has affected all of us since the beginning of 2020, and it is still around. We all have to remain safe and work together to bring this pandemic to an end so that we can go back to our pre-pandemic social norms. This is really unprecedented, and the information is coming to both the physicians and their patients so rapidly, as well as a lot of misinformation too. So it is very important, and it's a timely subject. And to provide us with the most up-to-date and timely information, we have a very well-known physician, Dr. Vishnu Chandi, amongst us. Dr. Vishnu Chandi is an infectious disease specialist of the Metro Infectious Disease Consultant Group here in Chicago, and he is the chair of the COVID-19 Task Force of Chicago Medical Society. He leads many COVID-19 related initiatives here in Chicago and the suburbs. We are very honored to have you, Dr. Chandi, and we truly appreciate you taking this time amongst your very busy schedule to provide our audience this timely information. And without further delay, we would like to start the program. And I would like to remind our audience that at the end of the talk, we will have a Q&A session. And if you can please type in your questions in the chat box or in the Q&A link, we will try to answer as many questions as possible. And lastly, I would like to remind everyone that this is an informational session only. And if you or your loved ones are having symptoms of COVID, please seek medical assistance from your healthcare provider or go to the nearest ER. So without further ado, we welcome Dr. Chandi. Thank you, Dr. Chandi, for being here, and the screen is yours. Dr. Chandi, I think your mic is off.
Is it now?
Yes, now we can hear you.
Okay, great. So I'm going to share my screen here. And basically, it's a talk about what's going on with COVID today and the myths and the facts about an update on the pandemic. So I'll control the slides. Can you guys all see the slides?
Not yet, Dr. Chandi.
You can't see the slides yet?
Not yet.
Share screen. Share screen. Share screen. Give me 1 second. I'm trying to share the screen here. Can you see the slides now?
Yes.
Okay.
Now we can see.
Great. Just, is it a full screen or do you see just like a broken up screen? Because I can't.
Yeah, it's a it's a broken up screen. It's not
okay. I'm gonna just make it a whole screen then. 1 second. Bear with me with the technical stuff here. Now, can you see the whole screen?
Yes.
Perfect. Okay. So I want to talk about an update on the pandemic and talk about myths and facts about the pandemic. Our group is about 120 doctors nationwide. We've taken care of about 150,000 1,000 people with COVID. And if you think about that, if you told me this a year ago, I would be in shock, but here we are. We've lost over 500,000 Americans. And so I just wanted to go over what the update on the pandemic is. And the slides are very technical, and that's basically for people who want more technical information. But I'm going to basically talk to the general public here. So where are we as a country in the pandemic? We have approximately 3 times as many people who have asymptomatic infection than symptomatic infection. And that's something that's new. We always thought that for COVID, it was going to be symptomatic people who are the most common, but we now recognize that there are many more asymptomatic people or pre-symptomatic people. That means before they get really sick. And the symptoms may just be a runny nose and a sore throat. Currently over 30 million people, over 30 million infections. We have about 80 to 90 million people with herd immunity. What is herd immunity? It was actually used in the veterinary literature to talk about cattle and sheep for hand, foot, mouth disease. But we've basically used this as a colloquial term for humans also. And herd immunity means that this many people have basically immunity to some partial immunity or complete immunity to this current infections. And what was the cost of that herd immunity? We see it every day on these tickers, well over 500,000 deaths. About 143 million doses of vaccine has been distributed. Most of that vaccine, in fact, almost all of it has been the 2-dose vaccine. So you cut that into 2. So it's about 72 million doses of vaccine have been given. At least 72 million have been given 1 dose of vaccine, with 38 million giving 2 doses of vaccine. And right now, we're at 2.4 million doses a day being given every single day into this country. So about a third of our country has some level of immunity. And the rates are falling, but there's this thing called the variants, which are viruses that have changed. And we're at a very critical time in this pandemic. And I always call it the inflection point. We either go one of 2 ways. We either get out of this pandemic and are able to carry on in pretty much normal life by July 4th, or we're going to go the way of Italy and we're going to end up having lockdowns and more mayhem. And that is something that we all want to avoid. So this slide is from this morning, and this basically goes over about 21.7% of the population has received at least 1 dose of vaccine. 11.3% is fully vaccinated, of which 267 million people are eligible. The total population of this country is 332 million. The problems with this is that there's vaccine and there's vaccination. You can have lots of vaccine. It doesn't do any good unless you have it in the arms of people, and that's called vaccination. And so there are a lot of people clamoring for vaccine, but there's a lot of people who don't want the vaccine. Up to 1/3 of the population doesn't want the vaccine. And interestingly, the House of Representatives today, 1 in 4 members have not taken the vaccine despite having the ability to take the vaccine for the last several months. So there's a lot of vaccine hesitancy. That's what this is called. It's more common in minority communities. There's also issues with access in minority communities. And interestingly, you can see that as the amount of infection is dying down, there's new hotspots arising throughout the country. In Chicagoland itself, this is brand spanking new. You can see where the hotspots are. If you see this area, it's where all the partygoers are, and a lot of our children out in Lincoln Park area in today's St. Patty's Day. So I hope our kids are not sitting next to each other, drinking beer and putting themselves at risk for COVID. This area up here on top, you can see is areas that are not are areas that are bordering the western suburbs, and these have become the new areas of hotspots for COVID. And we're seeing that in some of the hospitals we go to, we're seeing increased admission rates over the last several weeks. The other areas that were hotspots out here have cooled down significantly. So this myth about natural immunity, Rand Paul, who's an ophthalmologist and a physician, was touting natural immunity over vaccines. And that's one of the dumber things I've ever heard, because if vaccines were not as good as natural immunity, we should not be vaccinating anybody. Vaccines actually give you better immunity, longer lasting immunity, and much safer immunity than natural immunity. Because if you have natural immunity due to vaccine with infections, you'll have a lot more deaths. The threshold that our country requires, so how many people do we need to be vaccinated throughout the United States to stop the spread of COVID, is probably between 70 and 80%. So we're vaccinating a lot of people. We're doing it fairly quickly. The cost of reaching herd, if you get natural infection, it's very high. We've already have over 500,000 deaths. That's more than the deaths we've had combined between World War I, World War II, and the Vietnam War. And assuming an optimistic herd immunity of 50% in France and the US, that would translate in France to between 100,000 and 450,000 deaths. And believe it or not, in the United States, between 500,000 and 2,100,000 deaths, which is insanity. So currently, the reason why a lot of people who want the vaccine can't get it is we are shielding the people who are most at risk for dying, elderly and immunocompromised. But this has been complicated by policy issues. The policy issue is getting kids back to school. The reason why everyone wants the kids back to school is for each day of for preventing one death by closing schools, it costs the country about $11 million, believe it or not. Whereas if you put a mask on, it costs a few pennies. So getting the kids back to school is one of the more important things, because then the adults can go back to work, and that's why the teachers who may be young and healthy, not the older teachers who are at risk, are stepping in front of everyone else to get vaccinated, because it becomes a much more complex issue than just a pure medical issue. The immunocompromised hosts are actually not 1B. Their status as the CDC's designated a 1, 2, 3, and 4, 1, 2, 3 classification, and then 1A, 1B, 1C. 1C is immunocompromised hosts, and they've pushed up the teachers to 1B. They're cut in ahead of line here. So who's driving all this pandemic? It's the people that this was published in Science on February 2nd. And basically it shows that most of the people driving this pandemic are the age between 20 and 49. And these are the people least affected by the pandemic. But these 20 to 49-year-old people come home, and what do? They come home and they mix with the grandparents, they mix with their cousins who may be immunocompromised, and interestingly, they get them sick and they get hospitalized. And there's a lot of evidence that suggests that schools are not the cause of any increased rates of infection. And in fact, the CDC came out and showed in 2 articles, one in the Journal of Infectious Diseases, one in Clinical Infectious Diseases, that schools are not the source of infections. The MMWR also had a similar sort of thing, that schools are not the source of infections. And in fact, during the pandemic, schools were the safest place to be, especially for children as well as the teachers. Almost all the teachers who caught infections who were in school caught it outside of school, not within the school. So schools can be safely reopened, and actually can be reopened within 3-foot distances, not 6-foot distances. So what are we up against? We're in a race against time. And believe it or not, time almost always wins. If you are a student of Hindu literature, the greatest weapon of all time is time, because time is inexorable and nobody beats time. And this is a picture of a place called Manaus, Brazil. And Manaus is a sad example of what happens when bad government policy is taken, where they let the virus run wild. And basically 76% of the people were allowed to get infected, and the mortality rates were tremendously high. The interesting and the sad part about this was they thought this was going to be the way to fix it, but instead you had these strains that occurred called the P1 strain, which is a change in the virus that allows people to get secondary infections. So people who got infected before can get infected a second time. And this is what's happening in Brazil now. And in Brazil, it's gotten out of Manaus, which is a place stuck in the middle of the Amazon, and is now causing massive outbreaks in the major cities of Brazil. So this is not something that we want in the United States. We want to vaccinate everybody, and we want to prevent what's happening in Brazil. So, so herd immunity by natural infection is far worse than vaccine-created immunity. Vaccine-created immunity is longer lasting. It's much safer. So the myth, COVID-19 was created in a lab. Well, it's not true. It's from bats, and it transitioned to humans in the last few decades, not the last year. It's been decades. These are all the different coronaviruses that you see. You can see that group 1A, 1B, 2A, 2B, 2, and then you have 3A, B, and C. The current coronaviruses is called Sars. It belongs to group 2B, and it fundamentally affects the ACE2 inhibitors. But you can see that it affects many different types of animals: cats, dogs, pigs, rabbits. It affects other animals like minks. It affects turkeys. It affects peasants, and even a bulbul, if you know what a bulbul is. It also affects the Asian leopard or Chinese ferret or badger. And the coronavirus can go between species. So it can go from a bat to the human palm civet to the humans, and that's what caused SARS in 2004. It can go from humans to cows, and this is HCO. This is what's commonly the kids get all the time. And then from cows, it can change again and go to alpacas, and it can go to wild deers. And now there's a big epidemic between the alpacas and deer. It can go to dogs, and from dogs it can go to cats. And from cats it can go to, and then from the dogs it can go to pigs, and then from cat to cat. And that's called a feline coronavirus. So you have all these coronaviruses that affect many, many, many different species. So this older coronaviruses have relatively stable genes. They don't change very much, unlike the flu. In a single person infected with HIV, you may have like 100 and hundreds, if not thousands, of types of variants or changes in the virus. Whereas in coronavirus, it generally stays pretty stable. And coronaviruses have been around for a long, long time. It seems to have been circulating somewhere between 1948 to 1999. And it jumped to human beings somewhere in that period of time. And then you had enough humans being infected to cause this pandemic. So we think it's been circulating around for some time. And this is what's called the heat map. It's basically a representation of what we have now on the bottom here, which is from bats. It came to an animal called a pangolin, and then it got into humans. And the humans are now the major area where SARS-CoV-2 is spreading. So why do we care? We care because now we're having the virus mutate. And the virus is mutating because there's so much of this virus around. The amount of virus present throughout our areas is tremendously large. And these mutations are now causing significant change in the genome. And this changes relatively slowly, about 2 to 6 times slower than influenza. But now we're seeing many, many different types of variants. I'm not going to go into the details of these variants, but I wanted to go through some of them. So what are these mutations? Mutations are changes in the virus, and there are many different types of mutations. But compared to bacteria, so humans, think about yourself. You live somewhere between 60 and 90 years. Some people live to 100 years. You may have 1 or 2 generations, and if you're lucky, you may be able to see a 3rd generation. Okay, that's humans. So that the human lifespan is measured in decades to maybe not 100 years if you're really lucky. Bacteria, which we all have billions to trillions of in our body, mutate also. They mutate slower. They take days, whereas viruses can mutate hour by hour. And viruses can mutate very quickly. Now, viruses are the zombies of the world. They're neither living nor dead. They need other living things to spread. And viruses change by either changing their genetic material or they can delete things. So this virus has something where it can read and keep it stable. But if we have so much virus circulating in the community, you have breakthrough, what are called escape mutations. Normally, this virus mutates about 1 to 2 times a month, but in certain types of people, and our group, Dr. Han, wrote a paper about this in one of her bone marrow transplant patients, where the patient had virus persistent for months. And these are the types of folks, if they get infected, can suddenly have mutations that will completely make the vaccine almost worthless. In South Africa, they stopped using one of the vaccines, the AstraZeneca vaccine, because a variation in South Africa makes that vaccine very ineffective. So this is the fear of almost all infectious disease people and virologists. More circulating virus means more mutations. About 25%, as 25% of all infections in the world are in the United States. The United States may be the place where most of the mutations are taking place. The problem is we're not sequencing the virus, and sequencing is what we need to do to figure out if there are mutations. And so the virus, there's many different types, and this is called immune pressure. And this is the article that was written by Dr. Han, Dr. Rodriguez, and ourselves. The first virus that we saw, the first mutation that we saw was called the Eastern China mutation, the 614 mutations. This is the one that circulated throughout the United States. By March, it replaced most of the old original Wuhan virus. Then what you hear about in the news on TV all the time is this UK variant. It's called a B117 variant. And this variant is actually more infective. It's not probably more destructive, but it's more infective. There is some evidence that it actually is a little bit more dangerous than the original virus. And this virus tends to grow better. It tends to spread faster. And then it's picked up another mutation from South Africa where it's made it more resistant to vaccines. And this is called the South African variant. And this variant has become a huge problem in South Africa. And it's because of the fact that it is resistant to the vaccines. It's also resistant to some of the therapies we're giving. Then this is what caused all the problems in Brazil, the P1 variant. This P1 variant has this same mutation, this 501 mutation, and it causes people who previously been infected to be reinfected. And so, we may think, oh, I got COVID, I'm free. It's not true. You can catch COVID a second time. And that's why wearing masks, even if you've been vaccinated, is important until we get rid of almost all the COVID in our population. Then there are other variants, Danish variant, California variant called the Cal-20C. And this is why California had such a big outbreak when everybody else was not having such a big outbreak throughout the country. And this now is accounting for 35 to 44% of all the samples in California. And the South African variant has several mutations in it, which make the virus more infective and actually can make it a little bit more deadly. The South African variant arose from one person, a single person, and the single person allowed it to change to the point that now these treatments we have, such as monoclonal antibodies, as well as plasma, as well as the one of the vaccines, the AstraZeneca vaccine, is not very effective against this. And it increases the death rate in people who get infected. So the South African variant is a major source of concern for almost all infectious disease doctors, as well as epidemiologists and policymakers. So one of the big myths, once I get vaccinated, you don't need to wear a mask. In fact, I've had several physicians who believe this, and they're walking around the hospital saying, "Oh, you don't need to wear a mask. Why should I get vaccinated if I still have to wear a mask?" Well, masks are as effective as the most effective vaccine in preventing infection. So if you wear a mask, especially indoors, you must wear a mask if you're indoors and you're not within the group that you always live with, because you have people who are pre-symptomatically shedding. If you told me this a year ago, as an infectious disease doctor who's been doing this for a quarter of a century, I would tell you there was a rule, actually, you could not wear a mask within the hallways of the hospitals. And we had to change all these rules because we realized masks are really an effective way of preventing viral infections. For the audience out there, I have not had a cold in a year, which is the first time in my life I've never had a cold. And wearing a mask is the most effective way of preventing viral respiratory infections. So masks, especially during flu season, may be something that we may be using a long time to prevent infections. And what type of mask should you wear? Any mask is better than no mask, okay? Wearing a mask indoors is the most important thing. Masks work, okay? They work, but the type of mask is important. In the hospital, if you're at a very high risk, like we are when we go into COVID wards, N95 masks are useful, but they're impractical because N95 means 95% of the air that you're breathing in can't come in. So you will wear yourself out trying to breathe through that mask. Most of the people wear surgical masks, those little blue masks. If worn correctly, tight fitting over the nose, and you tighten it up correctly, it does prevent transmission. Especially if both people are wearing masks, it's very hard to transmit the virus. Cloth masks, it's dependent on making sure you wear them correctly, a tight fit. These little masks that you pull up over the bottom, worthless. They're not recommended because they tend to not fit correctly. There's very little evidence that they actually prevent a significant amount of transmission. Double masking is something that's come into vogue here. Double masking is very useful if you're wearing a cloth mask, okay, and then you put the surgical mask over it. But just remember, any mask is better than no mask. And if you wear a mask, and you must wear it correctly. The second big myth is, if I've been vaccinated, social distancing is not required. So what is social distancing? It's to stay far enough away so if you cough, the virus falls down. Almost all the virus is transmitted by droplet. There is some transmission by airborne transmission. Within 3 feet, almost everything falls down. And this was actually figured out during World War I, when we had our last big pandemic, which was the H1N1 pandemic, of influenza pandemic, that killed a significant proportion of the world. And they figured that out by experiments when they were transporting troops. When they put the troops 1 foot apart, a lot of the troops died. When they moved them 2 feet apart, a lot of the troops died. Once they moved them 3 feet apart, they realized almost nobody died. So 3 foot is what was considered adequate. And the WHO believes that 3 feet is more than adequate for COVID-19. And now there's lots of evidence that shows 3 feet is more than enough in schools if you're wearing a mask. 6 feet if you're not wearing a mask is required. So social 3 foot distancing, preferably 6 feet, especially if the air indoors is stagnant. Air turnover of more than 6 turnovers an hour is really important. Most grocery stores don't meet that. Most grocery stores are somewhere around 2 or 3 air turnovers an hour. And so grocery stores are very high risk for transmission. So if you go to a grocery store, designate one person, preferably somebody who's been vaccinated, to go grocery shopping. So indoor situations are a very high risk of spread, and until we have a significant amount of herd immunity and rates of transmission are low. Outdoors is relatively safe, very safe in fact, because the whole world is out there, and even a tiny breeze gets rid of the virus. Indoor events, bars, congregative settings, like if you're going to church and people are singing, very high risk of spread because that singing spreads the virus out there. Talking very loudly spreads the virus out into the areas. So in those areas, you must wear a mask. You must, in fact, singing and all that, wearing a face shield may decrease the amount of virus that's spread out there. So social distancing is really, really important. The air turnover is key. What is air turnover? It's the amount of air that's exchanged out of a room. Keeping a window open is very, very important. If you looked at countries, I come from India, and you think the Indians would have very high death rates. Well, India is a very young country, and death rates are directly correlated to age. So if you're 90, you're the highest risk of dying. If you're 80, second highest risk. 70, third highest risk. 60, fourth highest risk, and so on and so forth. So age is a big deal. But in India and in tropical countries, they keep windows open because they don't have air conditioning, and they keep fans on so the virus is dissipated. So keeping a window open is very, very important. It's very hard to do in Chicago if it's 30, 40, 50 degrees. Stagnant air with distancing less than 3 feet are major risks for spread in pre-symptomatic and asymptomatic individuals. Thus, keeping a window open, keeping social distancing, and turning the air over is very, very important. One of the hands and surfaces are key drivers in the pandemic. Well, that's not really true. There are minor transmission risks. It doesn't mean I'm telling you not to wash your hands, but contaminated surfaces play a minor role in transmission. Wash your hands between when you go shake hands and stuff, but that's not the major role of transmission. It's almost all droplet followed by airborne transmission. So you should clean surfaces with any disinfectant, and hands and surfaces play a minor role in transmission of COVID-19. It dies almost immediately, and the virus that's there is minimal. So these variants can cause problems. This is a scenario. If you have very fast vaccine rollout, you can see that that variant will become minor by the end of April. If you have the same behavior with no vaccination, 40% of the variants will become significant. If we have fast vaccine rollout and we get rid of our masks and everything else, this will become a massive problem, the variants. And where is all this going? If you watch the Schitt's Creek, that's where we're going unless we have significant improvement in the way we socially distance and we keep ourselves masked and we wash our hands. So if we do 3 million vaccines a day, okay, and we can achieve herd immunity by July, we'll probably have under 600,000 deaths, okay? If we relax our mitigation efforts, which is happening in Texas and Mississippi, and you have you achieve herd immunity by October, you'll have 170,000 people dying. If we get to 5 million doses of vaccine a day, then you'll achieve herd immunity by May. And that would be tremendous because you'll even have a lower mortality rate. If you remove all precautions, okay, and you don't do anything different, you'll have over 320,000 deaths compared to now by May. So that's not how you want to achieve immunity. If you have variants with no precautions and increased mortality, you can have another 530,000 deaths by November. And that is not what you want to do. So you must continue to wash hands, wear masks, and get yourself vaccinated as soon as possible. So COVID vaccine may cause COVID. Absolutely not. The current viruses are mRNA-based viruses, and the Johnson & Johnson is a modified adenovirus that cannot replicate within your body, and they only make a fragment of the virus, and it's not infective. So all these viruses are not live viruses. They are fragments, and it is very safe to take this vaccine. These vaccines are not developed overnight. The mRNA platform has been around for about 20 years, okay? They're about 95% efficacy. That means they work like the best vaccine is a measles vaccine, and this is the second best vaccine we've developed. The Johnson & Johnson vaccine, even though they say it is not as efficacious, it is 100% efficacious. It's 100% efficacious in preventing death and hospitalization. And that's pretty important. So why can't we just take one dose of vaccine? Okay, the mRNA vaccine. Well, because it induces neutralizing antibodies. You can take it in a single if you've had previous COVID, but if you've never had COVID and you only take one dose of vaccine, you increase your risk of creating these variants. So it's very important that you take both doses of vaccine. The only exception to that is if you've had COVID before, a single dose of vaccine may be enough. So these are all the vaccines that are available out there. There's the Mrna, there's the Pfizer, there's Johnson & Johnson, there's AstraZeneca. There's a new vaccine that's coming out called Novavax, and this is the Russian vaccine that's out there. And these all, look at this, protection from hospitalization is almost 100% of all of these vaccines. The efficacy in mild disease, that means having a runny nose or a sore throat, 94%, 95%. J&J is about 57% for the South African variant, but still very good because it's 100% effective against death. The AstraZeneca, 70%. The Sputnik, also between 80 and 90%. So all of these vaccines are very, very effective vaccines. So what is this new vaccine, the Johnson & Johnson vaccine? So this is, again, a platform that's been around for many years. It's been used in about 250,000 people during Ebola. And this is basically, adenovirus is your common cold. In 1959, they found this adenovirus, AD26, in a child. And then they modified the virus, and they made it so it cannot replicate within you. And what they do is they take the whole gene of what's called the spike glycoprotein, these little things that sit out here, okay, that your body recognizes as the virus, not the whole virus, just this little portion of the virus. And they inject the gene, which goes into your cell's DNA, and then it makes RNA, and then that RNA makes these glycoproteins. And these spike glycoproteins, what happened here? These spike glycoproteins your body recognizes and then makes antibodies to fight off this virus. And then it gives you immunity. And so when you looked at the Johnson & Johnson vaccine, who was vaccinated? About 43,000 people were put into randomization, of which 22,000 people were vaccinated. Look at the age groups, pretty good distribution, okay? And it's a very safe vaccine. The African Americans, Hispanics, and obesity, there were a good distribution of all of these folks, including HIV-infected patients. The countries that were studied were the US in 44%, Brazil, South Africa, and Latin America, and 23% of Latin America. And the people who had more adverse events is what you'd expect, the younger people. Why? Because they're more immune. They have better immunity. So if you looked at Pfizer, 80% of the people who took the Pfizer vaccine had pain at the site of injection, 85% for Mrna. Fatigue, you were tired or you had a headache, 50% of the time with Pfizer, 70 to 60% in Mrna. If you had fever, and you had about 15% on both, and in the lymphadenopathy was much more common in the Mrna, which is these lymph nodes. You get swelling under your arms, and it actually in women it was found that it could make the mammograms a little more difficult to interpret. The J&J vaccine had no lymph nodes. About 50%, half the people had pain at the site. It had fatigue in about 40%, let's say, and 9% had fever. So it's less, it causes less side effects than these other two vaccines. So we talked about the efficacy of these vaccines. It's very efficacious in all of these different variants, okay? Latin America, South America, and the US is a little less in South America and Latin America. South Africa and Latin America. And in severe disease, it protects you to 90%, but in hospitalizations, 100%. Okay, and that's really, really important. So it really prevents hospitalization and death. And for people over 60, it's very safe. And so it really does prevent severe critical illness in people without comorbidities with this Johnson & Johnson vaccine. So it decreased COVID infections in all population tested, regardless of age, ethnicity, and comorbidities. It probably decreases severe infections, and safe and well tolerated in all populations. Has a little bit more side effects in the young people. We don't know how long this vaccine will last. It has decreased efficacy in people who are older, and there's no data in children. There's no data for long-term side effects because it hasn't been around that long, and minimal data on duration of immunity. And how long a single dose it will last, we don't know. There's a trial going on with 2 doses. The reason why this vaccine is a game changer is because the Johnson & Johnson vaccine can be stored in the regular fridge. These other 2 vaccines require very cold storage and handling, and they require 2 doses, which is a very difficult thing to do worldwide because we have to basically vaccinate the whole world. Because what happens in the Middle East, South Africa, India, Singapore, connects us all together as a human race. Because a single person on an airplane could come over to Chicago and basically start a pandemic in Chicago. Our group saw the second person that was infected with COVID in the country. And here we are, 500,000 deaths later. By the way, that person did survive and did okay. So this adenovirus is, we already talked about this. It's basically a common cold virus that can't replicate within you. It's very safe. And so one of the myths that's out there is COVID vaccine may cause COVID. Nope, the currently licensed vaccines are based on small fragments, and they don't generate any live virus within you, so it cannot cause COVID. The new vaccines have not been adequately tested. We see in this country, we've already given over 70 million doses of vaccine. We have lots and lots of data that shows these vaccines are very, very safe. And the reason why these vaccines were developed so quickly was the US government basically paid these companies to make these vaccines, and they took all the risk. So they didn't have to worry about losing money. So COVID is here to stay. It'll be less pathogenic. That means it's not going to kill as many people, but it's going to cause lots of problems. As you can see, we already have issues with people getting from a year ago who've been sick, who recovered, and now they have something called long haulers. We're going to get better and better treatments for it, but vaccinations is the only way we're going to get out of this, along with wearing a mask, social distancing, washing hands, and being patient with what we're asking everyone to do for the next several months. So I'll stop there, and we will take questions because we have 15 minutes. Neeta, are you there? Hello.
Yes, Dr. Chandi, yeah, that was a wonderful talk, and Dr. Sudha Bopalan will ask you the remaining questions.
Thank you, Dr. Chandi. That was great. We had some questions sent by the audience. Some of this I think you've answered, but nevertheless, if I get the first vaccine, does that mean I have a little bit of the virus in me? Am I putting my spouse at risk if she did not get the vaccine yet?
So the answer is you're not taking any live virus. You don't have any virus within you. You only have fragments of the virus that give you immunity. This mRNA platform, you're going to hear about more and more and more, because not only is it good for vaccination, you're going to see it on treatments for cancer, because you don't need to take the whole virus or the whole immune portion. All you do is you take the immune portion. So your mother is safe, your family members are safe, your husband is safe, your wife is safe. Nobody's going to get infected from this vaccine.
Great.
So please take the vaccine.
Yes, thank you. The next question, is there a kids vaccine update?
Yes, they're testing now in children. There is no plans to start vaccinating children for another full year, because by the time we get everybody vaccinated, it will take a year. Children are immune tolerant. So children take up, when they get infected with COVID, and they do get infected with COVID, but not at the rate we do, simply because they don't have the receptors that we do. They don't carry much virus. They don't get very sick. Can they spread it to adults? They can, but it's at a much lower risk than adults spreading it to adults. The other thing is children become immune tolerant. Coronaviruses have been around in children forever. All of us who are alive today on this call have had coronaviruses. We've had it as children. It was a sore throat, runny nose. We didn't get sick because the coronavirus, our immune system did not overreact. Almost everybody who dies from coronavirus today dies because their immune system overreacts to this coronavirus and causes lung injury. There are very few people who die of the coronavirus invading their body and taking over their body. So children are at much lower risk. Children will eventually get vaccinated. Probably the trials are underway right now. Currently, the age of the children that they're trialing are 12 and above, and eventually they'll test in infants because that's not a priority group right now.
That's great. Yes, thank you. What to do after getting a vaccine if you have symptoms? Can you still take pain meds and go to work?
We actually looked at this as from a science perspective. There's no evidence that taking Tylenol or ibuprofen will decrease vaccine efficacy. We do not recommend taking, I can't stress this enough, we do not recommend taking Tylenol or ibuprofen before you get the vaccine, just in case. But if you do get symptomatic with fevers, chills, body aches, arm soreness, you can take Tylenol, acetaminophen, at 500 milligrams or 325 milligrams. Ibuprofen is a little bit more risky. It can cause ulcers, it can cause bleeding, so we don't recommend taking that without talking to your doctor first. So don't take it prophylactically, take it if you become symptomatic. Not everybody becomes symptomatic after taking the vaccine.
Thank you. That's great information. So don't take anything before you go, but certainly reach out for your Tylenol if you need to after the vaccination.
That's correct.
So how can seriously ill patients that are not yet 65 years old move up on the queue? They ask further, sorry, it's a longer question.
Yeah.
I have reached out to my practitioner, but he says to watch out the hospital websites for updates. I'm going through, sorry, couple more, two more sentences. I'm going through stage 4 cancer and my health is delicate. Also, my oncologist does not respond to my question. If I take the vaccine due to my low immune system, how do I know if the vaccine will be safe for me to take?
So the vaccine is perfectly safe for you to take. There's no contraindication to taking the vaccine if you're undergoing chemotherapy, period. The risk is you may not take up the vaccine, and it depends on the type of chemotherapy you're undergoing. I don't want to get into the technicalities of it, but basically if you're taking chemotherapy that infects your CD4 cells, your chances of taking up the vaccine are less. But I call this the vaccine hunger games. If you're very diligent and you look at your CVS and as well as your other local Walgreens are getting a lot of vaccine. Within the next 2 weeks, there'll be plenty of vaccine, 2 to 3 weeks, plenty of vaccine. The hospitals are the worst place to try to figure out if you get vaccine because they're not on the queue to get vaccines. The places to get vaccines are your local health departments, your CVS, and these vaccine fairs. Interestingly, a lot of the vaccine fairs have excess vaccine at the end of the day that they must give out. So checking all these different sites, you should be able to get vaccinated within the next few weeks. We're having the same problem for our immunocompromised hosts. We're having a tough time finding enough vaccine so we can do it in an orderly manner. People are just scrambling. What I stated as the vaccine hunger games. We're trying to find vaccine. So go to as many websites as possible. Go to CVS. If you have the pharmacist there, when they have, make sure that they have you on the list there, and they'll call you. A lot of people end up getting vaccine at the end of the day because it's available for them, and then they get the second dose 3 to 4 weeks, depending on the vaccine that's available for you.
Yeah, I think this question brought up a lot of important information. Really, there is not that many people who cannot take the vaccine. Is that right? Almost everybody can.
Almost 100% of the people can take the vaccine. The only people that cannot take the vaccine are people who've had hypersensitivity reactions to the first dose of vaccine where they've developed a severe reaction, whether it's a low platelet count, whether it's some sort of a strange nerve issue, but those are 1 in a million. There are not many people. This has been an extremely safe vaccine. It's painful. I mean, I took the vaccine as soon as it came out, and the second dose, for 1 day, I was sick, but that was okay because the sickness that you get from the vaccine means your immune system is working. It's much safer than getting true infection. I've never seen this many people die in my life. I mean, it's just so sad to see older people pass away like this alone. And so I would tell everyone that's out there listening, please get vaccinated. Don't fear the vaccine, fear the virus. Do not fear the vaccine.
Thank you, Dr. Chandi. I think we have a few more questions. How risky is it to swim in an indoor pool?
It's not risky at all. The problem is not the indoor pool. The problem is, where do you shower and where do you, the bathroom area where people may congregate. If you're very clear about wearing a mask as soon as you get out of the pool, and then you take your shower, and then you wear a mask when you change, you should be okay. It's the bathrooms and it's these areas that people congregate. It's not the pool itself. And it's getting in and out of the health club or where you're going. The swimming pool is not the issue. It's the logistics of getting in and out of the pool and then getting changed. That's the issue. If everybody's good about that, it should be a safe endeavor.
That's good. And going to the next question. If allergic to flu vaccine, can we take the COVID vaccine?
Absolutely. Two different vaccines. Influenza vaccine allergy is usually an egg allergy, and now they have egg-free influenza vaccine. Even if you've had things like Guillain-Barré, this vaccine has not been shown to cause Guillain-Barré, so it is safe to take it. There's this thing that everybody talked about called Bell's palsy, which is, your face on one side gets paralyzed. The risk of Bell's palsy from this vaccine is no higher than the general population. So you can take this vaccine regardless. One of my own partners who had Bell's palsy, we gave her the vaccine, no side effects.
Okay, that's good to know. And I think you did answer this question in one of your slides. If a person suffers from COVID-19, can we get reinfected again?
The answer is yes, unfortunately. Most people will not get reinfected in this country. The problem is what we talked about, is the variants. If you start getting variants in this country, which are unresponsive to vaccination and are so different, so the virus has changed to the point that your body does not recognize it. It's like an old girlfriend or boyfriend that you can't recognize anymore. You see them in somewhere 40 years later and you go, is that you? Your immune system may do the same thing, and it may not recognize the virus, and in which case you can get reinfected. And the issue is with this vaccine, with the infections, just because that's why you have to wear masks, because you want to decrease the whole community viral load, the amount of virus that's being spread in the community, to a small amount. And so we don't get variants that can cause immune escape. So yes, you may get infected with a second infection. That's why you must wear a mask, socially distance, and wash your hands.
Okay, sounds good. And then the other question is, I had my first dose of Mrna vaccine and ready to get my second dose in few weeks. Is there anything that I can do before or after the shot to ease the reactions?
You really can't. The second dose, the younger you are, the more likelihood that you're going to have reactions. The older you are, the less the likelihood that you're going to have reactions. Older meaning more than 60. You can take Tylenol after your vaccine if you're having fevers, chills, body aches. Other than that, it's a small little prick on your arm. If you're right-handed, you make sure they give it to you in your left hand. If you're left-handed, give it to your right hand. Don't try to work the following day if you're in heavy labor. If you have to dig or do things like that, don't plan on stuff like that. Don't plan on an extensive work schedule the next day. Take it easy that following day. That's really kind of important for that.
Okay, sounds good. And one last question from me. There was a question about if we need to take the booster shots as soon as the coming fall.
Booster vaccines are being tested. Yeah, booster vaccines are being tested right now, which covered some of those variants we talked about. We don't know the timing. It depends on the amount of virus and the amount of incidence in this country. So we will have an update as soon as we have better data on that.
Sounds good. I think we may have time for a few more questions. Dr. Sudha Bopalam will ask the remaining few questions.
I think we have time for a couple more questions. So it was all great information so far. So what about visits? How about visiting people who are vaccinated, who are not vaccinated, or people who have health conditions, cancer? What can you tell us about visits?
So two scenarios. This is the number one question that I'm getting currently from my physician colleagues and other friends. Can I visit my father? Can I visit my mother? Can I visit? So if everybody's vaccinated, that means you're vaccinated, your spouse is vaccinated, the people that you're going to visit are vaccinated. It's generally safe to visit, as long as you're not going to have, a party of 150 people. If you're going to have 6-10 people, you can visit. if everyone is vaccinated. Now, what happens if people are not vaccinated? Well, the person that's not vaccinated must wear a mask, and you must also wear a mask and keep distancing from that person. So if there's a mixed congregation of vaccinated and unvaccinated people, same rules apply. Wearing a mask, trying to stay outdoors, and if you're indoors, everybody has to wear a mask. If you're visiting grandparents, so grandparents are vaccinated, scenario number one, and you're vaccinated, you can visit them, and you're generally safe. Is it 100% safe? Not 100% safe, but life, has relative risk. Is it safe enough where it's worthwhile to visit? Absolutely. And this is called relative risk. What is your risk aversion to this? There's a certain benefit we get from seeing one another and talking to one another. And that's where I think you have to balance out this scenarios. I do think seeing our parents, our grandparents, and our families are really important. And I think that is worth the risk, provided you explain that risk to people. Don't do anything crazy like, go to a wedding with 1,000 people and not wear a mask. That will definitely get you infected if you've not been vaccinated. Even if you're vaccinated, 40%, 35 to 40% of the people may carry virus for a short period of time if you get exposed, because this vaccination does not stop you from carrying the virus. It prevents you from getting infected and sick from the virus. So you can carry it and pass it on to someone who is susceptible. And remember, we still have 2/3 of the population that's still susceptible to catching the virus. So wear your mask, distance within 3 feet at least, wash your hands.
This is such welcome news for the grandparents who have not seen their grandkids in a year, and for all the people who really have been not going out and meeting anyone. Is it safe for my child to go back to school if the distance is 3 feet apart?
My answer is yes. We've been recommending that and actually talking to the school boards. Actually, I think I spoke with Schaumburg School Board many, many months ago about this, that it is 3 feet distancing is safe. It's been shown in 2 major studies now that show that as long as kids wear masks and follow all the other guidance, it is perfectly safe to have 3 feet distancing, so you could have almost all the kids back to school. This is incredibly important for kids between the ages of 3 and 12, and equally and almost as important between the ages of 12 and 17. And so, and especially now that we have 85 to 90% of the teachers vaccinated, time to get back to school 3 feet apart, wash your hands, and wear masks in that scenario.
So let's take the last audience question. If we have a choice, what company vaccine would you suggest?
It doesn't matter. All these vaccines are very, very good. I don't have a preference, and I can tell you this honestly. At that time, I got Pfizer. My kids got Moderna. My wife got Moderna. My daughter, who's immunosuppressed, got Moderna. And it is what it is. Take the vaccine that you can. There's lots of vaccine available. You'll find, and there are places that they're not able to give out enough vaccine because there's so much demand. And there are other areas where there's lots of vaccine and no demand. And so we have to get this correctly. So take any vaccine that you get. I have no preferences. I think all these vaccines are unbelievably good vaccines.
Okay. So I think that's all the time we have questions. So that was great. Audience, I hope you enjoyed this and learned from this as much as I did. Thank you for tuning in, and thank you for your participation. Please remember that this is informational, and you should take your specific healthcare questions to your provider. We went on COVID lockdown a year ago in March of 2020. Who would have known that a year later we'll still be in the midst of the pandemic? However, there is light at the end of the tunnel. Thank you, Dr. Chandi, for teaching us about the virus. What can we do to protect ourselves? And most importantly, about the vaccines. The vaccine.
Thank you for having me. It was a lot of fun doing this.
Absolutely.
Thank you,
Yeah, like we learned, the vaccine is the light at the end of the tunnel. As we learn now, there are 3 vaccines now available to us. There are mass vaccination sites in Illinois, expanding access to the general public. All of this gives us hope. Yes, hope is in the air, as is spring. Spring always puts a smile on my lips, and to me, it's a season of hope. As you rush outside to greet Mother Nature, hear the birds chirp, or see the tender saplings sprout through the snow-covered ground, don't forget your mask. Don't forget social distancing. Do your hand washing. All these precautions that you've been taking to keep yourself safe, keep with it. COVID is a marathon, and we don't stop at mile 26. We have to go all the way to the finish line. And with the vaccine and the precautions that we will take, we can finish strong. Thank you to Schaumburg Public Library for hosting this event, and a special thanks to Mrs. Sangeeta Bhargava for working with us at IAMA to make this event happen. Audience, if you like this, we have more educational sessions planned for you. Please tune in next month, April 28th, for an educational session on colon health awareness. So it was great spending this last hour with all of you. Good night, everyone, and take care. Signing off.
Thank you.
Thank you.